We're going to talk about local anesthesia, as well as general anesthesia and some of the mechanisms of action behind those different types of drugs and the clinical application for those. And then we're going to talk about ions and how they're involved in signals. And then we're going to discuss the giant squid. So the giant squid neuron is what was used originally to be able to study how neurons actually work. The giant squid neuron is huge. And by the way, here's a quick question for you guys. What is the largest cell in both male and female humans? Because the answer is different if you just focus on the largest cell in a female. Yeah. So in a woman, the largest cell is actually the ovum. It's huge. It's actually really big. If you look at a picture of an ovum, you can look it up online, next to a dime, it's like, you can see it with the naked eye. You can see it's about like 1/15 the size of a dime. So it's actually pretty big. The largest cell that's known on Earth is what? It's also involving an egg.
A whale egg?
No, actually it's an ostrich egg. The ostrich egg is the largest cell known to us on Earth. Now, between males and females, what is the largest cell? It's actually a neuron.
Oh. Duh.
Which neuron do you think it is? Have you guys ever heard of sciatica? When a person gets sciatica, the sciatic nerve is the largest cell between both men and women. So the largest cell in the body is actually a neuron. So very cool. Giant squid cells are really huge, so they're really easy to be able to test to see how, ions flow in and out of the cell depending on which stage of depolarization you're looking at. So we're going to talk about that a little bit later. And then we're going to discuss the Nernst versus the Goldman equation. So these are equations that basically calculate the ways in which ions flow in and out of a cell. The Nernst equation, the big difference between the Nernst and the Goldman is that the Nernst equation looks at just one ion at a time, whereas the Goldman equation factors in multiple different ions. So it kind of reflects what you really see in reality, right? The Goldman equation. So we're going to talk about that later on. Some of these equations can tend to be a little bit complex and convoluted. I don't want this to turn into a math class. So just understand the general concept behind the equations, but I am not going to make you guys calculate stuff on the exam. So you're not going to have to calculate the Nernst equation using the Nernst formula or the Goldman equation. All right, so resting membrane potential. This is when a cell is not being stimulated whatsoever, right? At rest, the membrane potential could be anywhere between -40 to -90. Now, these potentials are going to vary depending on what cell you're looking at. But on average, it's going to be anywhere between -40 to -90. Receptor potential, this is going to be involving sensory neurons. Okay, so now think about your reflex, right? When you have a reflex. Remember we talked about the patella reflex? Whenever you strike the patella tendon, that's going to be affecting the receptor potential, right? So that's going to be sensory type of neurons. Then the next thing that happens is you have a synaptic potential taking place. And that's going to be communication between two neurons, and that's going to be across a synapse. Now, a question that a lot of you guys missed on the exam is, what is a synapse for? I think the majority of you guys missed that question. I think one person got it right. So one of the questions on the exam last week was, what happens at the synapse? The synapse is going to be a really narrow space where you have the movement of neurotransmitters, right? That's the definition of a synapse. And so I forget what the option was that most of you guys selected, but there was one other option. But that was the correct answer. So synaptic potential, that's going to be what takes place when you have two neurons in communication with each other, and neurotransmitters are going to be involved in that communication process. And then you have the action potential, and that's where you have the impulse being sent along the entirety of an axon. So if you were to look at the patella reflex Again, receptor potential is going to be what is stimulated. Then you have your afferent nerve fibers coming into communication with either the motor neuron or an interneuron. And then you're going to have synaptic potential between those two neurons. And then you're going to have an action potential that gets sent all the way down the axon. So in terms of axon anatomy, we discussed this a little bit before, but let's go into it again. In order for a neuron to actually depolarize, you have to have stimulation to threshold at the axon hillock. The axon hillock is going to be effectively the trigger for the neuron. If you are receiving signals from a neuron upstream and you're getting signals sent to the dendrites, if it doesn't allow for depolarization at the axon hillock, you're not going to get any depolarization taking place, right? You're going to get sub-threshold communication. It has to hit threshold in order for you to actually get a propagation of the signal all the way down the axon. So think of the axon hillock as a funnel. It's a funnel for ions and chemical signals to come through, and then only when it hits threshold is when you actually get the full-on depolarization. So here are your axon terminals. Axon terminals are also referred to as synaptic terminals, also referred to as synaptic knob, also referred to as the terminal button. But for the sake of this class, I'm just going to refer to those as axon terminals. So just to keep things simple. What is this, an axon terminal? Basically, it's a bulging out at the very end of where you were able to develop a synapse. So you get this kind of like bulging structure forming the synapse. And that's where you find those vesicles that get released, right? We're going to talk about different types of neurotransmitters and the receptor sites that they bind to, but you probably recall some of those neurotransmitters from A&P, right? What's a really common one that we talked about before in A&P is, well, GABA is one, but acetylcholine. Acetylcholine is going to be one of the most ubiquitous neurotransmitters in your body. And acetylcholine is involved in lots of different things. Acetylcholine, for example, is involved in muscle contraction, right? When acetylcholine gets released at the neuromuscular junction, and then it goes to the motor end plate, that's where you find acetylcholine receptors, then it's going to allow for the stimulation of muscle contraction. And so that's one example of a neurotransmitter. So again, we're going to talk about those neurotransmitters in more detail later on as we get closer to next week. That's when we're going to start talking about different types of neurotransmitters. So here are your different neuronal signals. If you were to do a microelectrode, this is how we do measurement of neurons and how they fire. You use little microelectrodes, and they can give you electrical readings of what's going on at the level of the cell. A over here is describing what would happen if you have touch, right? Pacinian corpuscles, those are what respond to changes in pressure. And so if you had changes in pressure or like vibratory type information sent to your skin, it's going to stimulate the Pacinian corpuscles to fire off. And then so you'll get a little action potential as a result from that. Activation of synaptic contact. So here's your synapse. You got an axon here, and then you have the dendrite of the receiving cell. If you stimulate the synapse, then you're going to be able to see changes within the cell body of the receiving cell, right? And so eventually, if that cell communication gets to a certain point, then at the axon hillock, that's when you would actually see a full-blown action potential. And then here again is your spinal reflex, where you have action potentials being sent down to your motor neurons. Now, there's a couple different types of signals that can take place. One is going to be passive electrical signals. And this basically just kind of happens. It doesn't have any sort of unique properties to it, but it does happen in response. It can happen without any response from a signal. So this can just happen randomly. So passive electronic responses. And then we have hyperpolarization. Hyperpolarization is where stimulus that causes the membrane to become more negative than the rest of the resting membrane potential. That's going to be your hyperpolarization. And then you have your active electrical response. And that is going to be where you have threshold being met, and you can go beyond threshold, and that's going to be involving your threshold potential. And that's where you get the actual depolarization. It's from active electrical response. So we're going to talk about the difference between both passive and active electrical response quite a bit over the course of today's lecture. So to review how action potentials take place, right, you have the nerve impulse, right, and then basically it turns into a wave of a signal. The wave of the signal is also going to leave behind a wake, right? You guys ever like go boating or anything like that? You have a wake that is left behind when the boat's moving forward. Something kind of similar happens in the wake of an action potential. So the wake is going to be involving the opening and closure of different types of ion channels so that basically the signal doesn't go backwards. So it basically propagates in one direction towards the axon terminal. We'll talk about that process later on. So it's going to involve sodium as well as potassium channels. And then here are your major stages. This is again review. So you have depolarization until you hit threshold. Then once you hit threshold, you get rapid depolarization. Then you get, depolarization. Then you get repolarization back down to negative value. And then you also see hyper repolarization. So it kind of overshoots down and then it goes back to normal again. So we'll talk about that process a little bit later. Again, resting membrane potential, it can be anywhere between negative 40 to negative 90. But let's just think of it as, for sake of simplicity, negative 70. And at resting membrane potential, all the channels are going to be closed, right? You're not going to have movement of ions. And then the graded depolarization, that's where you start getting maybe influx of sodium, right? That's going to slowly kind of change the charge of the cell. You can also have chloride ions involved in that, which would send the resting membrane potential to a more negative value. We're going to talk about that involving like GABA. For example, GABA is going to involve chloride ion channels. So whenever you have influx of chloride ion, it makes the resting membrane potential even more negative. So that's why things like GABA are neuroinhibitors. It makes the resting membrane potential more negative, makes it difficult for that cell to actually depolarize. And so different ions can come into this, the whole entire process. And then once you hit threshold, that's when you get the rapid depolarization. So that's going to involve sodium. Sodium is going to be the major player in rapid depolarization. And then depending on what neuron, it can go all the way up to about positive 50, positive 30 to positive 50. This textbook focuses on certain neurons that go up to positive 50. So it can be kind of a range, right? Different neurons look different in terms of their voltages. Then you have repolarization. What happens at repolarization? Those voltage-gated sodium channels close up. So once you hit the top of the peak, you're going to get those channels closing up, and then that's when you have potassium coming in, and potassium is going to be the major regulator of resting membrane potential. And so potassium is going to rush out of the cell, and it's going to bring it down to a negative charge again, right? And then it's going to overshoot. So that's where you see hyper-repolarization. And then once you have hyper-repolarization, that's when those potassium channels finally close up. And then you can reestablish the resting membrane potential with one of the most important channel proteins, or membrane proteins, the sodium-potassium ATPase. Right? The majority of ATP produced by a cell is going to be dedicated to the sodium-potassium ATPase. And here's, again, a review of how an action potential is sequenced, right? All the different ions that are involved in that, sodium rushing in during depolarization, potassium rushing out during repolarization, and then the hyperrepolarization at the very end, where the potassium channels finally close. What's up?
2 questions.
Yeah.
1, this is similar to what you want for part 1 of the project, right?
Basically.
Question 2. So you know how when repolarization occurs with potassium channels opening? What if someone in the body doesn't have enough potassium?
Oh, yeah, that would definitely affect it. So when you have ion imbalances, in general, a lot of those affect your neurons. So if you have sodium imbalance, oh man, I was supposed to put in
Did I catch you off guard?
Yeah, no, you reminded me of something I was going to include in the lecture, but I totally forgot. I was going to do it last night, but my neighbors stopped by to bother me. So yeah, we'll talk about, let's actually talk about it now. Sodium is involved in depolarization. What happens if you don't have enough sodium, if you're hyponatremic? Are the neurons going to be able to fire properly? No, they're going to.
When you're not, is it when you're spastic or flaccid?
It's the opposite. Yeah, it's going to cause flaccid type paralysis. If you don't have enough sodium, you're hyponatremic. You're going to be hyporeflexive.
Hypokalemic.
Well, that we'll talk about that in a second. But if you have too little sodium, you're going to be hyporeflexive. So if you did a patella test, right? If you hit the patella tendon, you're going to see reduction in reflexes.
So it won't extend that much.
Now, if you have way too much sodium and you're hypernatremic, you're going to get the opposite. You're going to have accentuated reflexes. So your reflexes are going to be exaggerated. You're going to be hyperreflexic, and you might have also spastic type paralysis because you're having way too much activation of the neurons. Potassium can also affect the neurons too. As a matter of fact, potassium is one of the ingredients to lethal injections. So whenever they execute a prisoner, for example, on death row, those injections, a huge component of that is potassium. So they throw basically their neurons off balance. And also, if you look at the way cardiac myocytes operate, they operate very similar to neurons. They're involving sodium and potassium. And so you can actually affect the heart and cause dysarrhythmia if you give the person way too much potassium. They can also have issues if they have way too little potassium too. So these ions play a really important role in neurological function as well as cardiovascular function as well. So that was a really good question.
You said for the potassium, if it was too much, you would have like constant firing?
No, more so the sodium. Potassium, if you had too much potassium, that would probably affect the ability for potassium to leave the cell. So that would make it probably more difficult for repolarization. Okay. So yeah, that would probably.
What was the thing you had just said with potassium?
If you had too much potassium, it could also affect your heart. So it could also cause an arrhythmia. So it puts you into, they call it a sinus, they call it like a sinus type pattern. And that would throw your heart into an arrhythmia. Sinusoidal type of pattern on the EKG. You can actually see those types of ion imbalances on EKG. But anyway, so this is like a review of how action potentials work and all the different ions involved in that. Action potentials in neurons are all or nothing. If you don't reach threshold at the axon hillock, you don't get anything, right? So it's all or nothing. You have to hit threshold in order for an action potential to be propagated. It is not decremental, meaning it doesn't get weaker over distance. However, there are conditions that can make that happen. So myasthenia gravis, multiple sclerosis would be an example of that. Same thing with Guillain-Barré syndrome. That can also affect the myelin sheaths. So if you affect myelinated axons, you could see the signal getting weaker with distance. And then once you activate a neuron and you depolarize the neuron and reach threshold, that's irreversible. And then we're going to talk a little bit about, we're going to talk a little bit about how the refractory period. Right, so the refractory period is once you stimulate a neuron, and if you try to stimulate it again right away, it's not going to stimulate. Right? It has to have a moment of rest, basically, so that you can kind of re-achieve the ion gradient, right? The concentration gradients. Yes?
Do you know why it doesn't get weaker over distance?
It's myelin.
So that just like...
Yeah, you have saltatory type signals, right? You have, it's saltatory, meaning it jumps from every node of Ranvier, which we're going to talk about a little bit later when we discuss myelin in part 2 of this lecture. Myelin is basically what allows for the nerve to maintain its, like, the integrity of the signal. If you have demyelination, you lose that signal. The signal gets weaker over distance. And yeah, basically you just have leaky cells, leaky axons.
Are the channels at the nodes of Ranvier?
Yeah. So you have voltage-gated sodium channels in every single node of Ranvier.
Okay.
And potassium, voltage-gated potassium channels, not every single node, but you see them in the nodes of Ranvier.
So you won't find them on the
on the actual cell? Well, because it's not necessary on oligodendrocyte. Oligodendrocytes are just supporting cells. So like your glial cells, neuroglia, they're just supporting cells, right? The actual neuron is where you're going to see those voltage-gated channels and whatnot. I mean, you might see those on other glial cells, but it doesn't play a significant role, at least in terms of action potential. So you might see that in other cells, but I'm not sure in terms of like comparing and contrasting. Like, let me just look that up real quick. So you're talking about sodium channel?
Yeah.
Voltage. You probably do. So you do find them. Their expression is restricted to the earliest stages of differentiation, being downregulated during maturation of the oligodendrocyte cells. So it's not as important. It's going to be much more important in actual neurons that have actual axons for the purpose of cell communication. So you get the absolute refractory period. Again, at that point, you're not going to get another stimulation of that nerve. Right? Once that nerve gets stimulated, that's it, and it's an all or nothing signal. And then you have a relative refractory period. A stronger stimulus would be needed at that point to be able to get another action potential to take place. So,
I'm confused.
yeah.
So I thought you said that like when a neuron is stimulated that it needs to be rested to start up again, but then you just said that no stimulus of like anything would trigger another action potential.
Yeah, so at the absolute refractory period, no additional stimulus would cause further firing.
So you can't like reuse.
Yeah, so at this point right here, if you try to re-stimulate that neuron at that point, at the absolute refractory period, it's already being stimulated. And so like I said, it's an all or nothing. Once those channels are going to open up and it's going to reach the peak with sodium influx, right? And then it needs to go back down again for you to get another stimulation. But the relative refractory period, you might be able to re-stimulate that neuron, but it has to be a really, really strong signal to be able to do that.
So does it do that by like increasing the threshold?
You're talking about the relative refractory period?
Yeah.
Yeah, I guess you would have to go beyond the threshold. Yeah, that's a really good point. So here are your active versus passive responses. So over here you have passive response. Again, that kind of just, sometimes it can happen spontaneously, but it's basically like the neuron is kind of, the ions are just kind of like flowing in and out of the cell. Only at the point where you have the active response, when you have an actual action potential, when you hit threshold, that's when you're going to get the full-blown spike. Right? That's when you get the spike, the neuron actually signaling. There's other things too that can cause hyperpolarization. Again, your neuroinhibitory cells, GABA neurotransmitter, it's going to cause chloride to come into the cell. So it will change the overall charge of the cell. But you're not going to see anything really happening until you reach your threshold.
Chloride's negative?
Chloride's negative, yeah. So sodium, positive valence, chloride's going to have a negative valence. And so if you had microelectrodes, basically measuring the cell, you have one that's in the cell stimulating, and then you have one that's actually recording the membrane potential. So you stimulate the neuron and then record it. That's what's going on over here in this chart. So here's your threshold. Again, you have your passive responses, and then you have your actual action potential. So in this particular study, they were looking at stimulation of the neuron and seeing how that affects the ability for the action potential to take place. So you do see some depolarization signals happening when it's sub-threshold, but doesn't actually cause any sort of action potential. But once you get full-blown threshold being reached, then you have the actual depolarization and then the subsequent action potential taking place. Again, all or nothing. So you have to reach threshold, otherwise you're not going to get any signal whatsoever. Stimulus intensity is encoded by the frequency, right? The action potential frequency. So the faster a neuron fires, that's when you get a greater amount of actual frequency, right? So it's not going to be amplitude. Amplitude does not change, right? Once you hit an action potential, the amplitude is going to be set depending on the neuron, at a certain value, whether it's like positive 30, positive 50, right? That's the amplitude. But the amplitude doesn't change in the neuron. It's going to be the frequency. That's what's important, right? Remember we talked about spikes a few weeks ago? That's how the neurons communicate. When you have spikes, that's a set amplitude. It's only the frequency that's going to be important. Compared with subthreshold responses of receptor potentials whose responses are graded in proportion to stimulus strength or intensity. So this is going to be different than graded potential. It's going to be involving frequency, not gradations. All right, now passive current flow. This type of flow, this is where like ions are just kind of like moving around within the cell, and it's going to sometimes happen randomly. And these types of ion signals are going to, over time, just kind of decay. So they're not going to have any sort of significant effect on the actual action potential. So here's an example of an unmyelinated axon. So squid axons are going to be unmyelinated, and it's going to eventually just decay over time. So here's an example of a squid axon. So we're going to talk about squid axons a little bit later. But if you had to if you stimulated the axon, it's only going to have a significant effect close to the actual stimulant, the electrode that's going to be stimulating the axon at that one spot. But as you get further along the distance of the axon, if it's unmyelinated, you're not going to have propagation of the signal. So this is going to be an example of passive flow. So passive flow basically degenerates over time. So here's the amplitude, the change of membrane potential. As you can see, the membrane potential slowly dissipates as you move further and further away from the stimulus. Now, active current flow. Active current flow is where you have the maintenance of the signal throughout the duration of the axon. So it does not decay with distance. It remains the same. And you're going to have a constant amplitude. Remember, the amplitude does not change. Once you hit threshold and you get a good signal propagating along the axon, the amplitude remains the exact same. So here's a good depiction showing how the amplitude does not change. So over here, amplitude remains the same all along the course of the entire axon. And so that's going to be involving the active current, right? So that's active current flow of ions. Now let's talk a little bit about anesthetics and how those work. So again, this is going to play into your guys' assignment coming up. There's multiple different types of anesthetics. The broad categories, though, in terms of like clinical application, it's local versus regional versus general. Local anesthesia, you're not going to be knocked out. You're still going to be conscious, right? So, I had a sebaceous cyst on my back once, and I had it removed. And actually, he used to be my best friend in middle school. We used to like skateboard together, and then he became a nurse practitioner, and he was actually the one that did the surgery on my back. So it's like my middle school best friend. And how did the surgery go? Just local anesthesia. So local injection of lidocaine. He was able to remove it, and was absolutely no issue whatsoever. Regional would involve a little bit larger of an area. So remember your nerve blocks. We talked about like epidurals, for example. So during like labor and delivery, you'd want to do a nerve block so that mom doesn't feel the pain while she's delivering the child. So that would be considered a regional anesthetic. General anesthesia, that's when you lose consciousness, right? If you're going into like a major surgery, for example, and you're in the OR, you're going to undergo general anesthesia. And that's when you're going to lose consciousness, and basically all your muscles are going to be relaxed as a consequence. And again, there's multiple different types of anesthetics. We talked about lidocaine, which works as a sodium channel blocker. Propofol is going to be a different type of drug. So this drug has a really cool name, milk of amnesia, because it looks really milky if you look at it. And the way that this one works, it's going to be working through GABA. And so it's going to involve positive modulation of GABA. So if you stimulate more release of GABA, then you're going to basically cause neurodepression, right? So GABA is going to cause neurodepression, reduction of stimulation of the neurons.
Is that like the most commonly used one?
It's every single surgery that I've personally been involved in, propofol was involved. It's very common for like induction of anesthesia.
I went and watched like 6 colonoscopies, and that was the only thing.
Yeah, I think it's you. If I don't quote me on this because I'm not an anesthesiologist, but I'm
That's the main thing.
every single surgery I've ever been part of, propofol was involved. And there's different types of anesthesia, which we're not going to go into in this class. But there's induction type of drugs where you induce the patient, and then there's maintenance drugs. So you maintain the anesthesia throughout the duration of the surgery. So you induce, knock the patient out, and then you maintain it with different types of meds. And then a lot of times you have to do a balancing act because sometimes these drugs affect the central nervous system, right? So that's going to cause depression of the heart rate. It can cause depression of your vitals, right? So if it gets too low, that can be pretty scary. So anesthesiologists are constantly observing the vital signs on the patient, making sure they're not administering way too much of the drug. Otherwise, the patient could potentially die on the operating table if they go into like a fatal arrhythmia, if their vitals get thrown off for whatever reason. Propofol is also the drug that killed Michael Jackson. Michael Jackson was taking propofol. I don't know why. I didn't really look into it, but that's the drug that's what killed him.
Is this the general one? Like an example for general type?
Propofol, let me see how it's used in term if it's induction or it's a general anesthetic. But propofol, I don't know if it's induction or if it's maintenance. What drugs are used to induce?
I was Michael Jackson.
I have no idea. So the drugs are used for inducing anesthesia are propofol. Ketamine is also another one. Adjuvant agents could also be used too, like opioids, lidocaine, midazolam. Let me see, what drugs are used to maintain general anesthesia? Propofol is also used to maintain. So, anyways, good stuff. So let's watch a little thing on anesthesia here.
If you've had surgery, you might remember starting to count backwards from 10, 9, 8, and then waking up with the surgery already over before you even got to 5. And it might seem like you were asleep, but you weren't. You were under anesthesia, which is much more complicated. You were unconscious, but you also couldn't move, form memories, or hopefully feel pain. Without being able to block all those processes at once, many surgeries would be way too traumatic to perform. Ancient medical texts from Egypt, Asia, and the Middle East all describe early anesthetics containing things like opium poppy, mandrake fruit, and alcohol. Today, anesthesiologists often combine regional, inhalational, and intravenous agents to get the right balance for a surgery. Regional anesthesia blocks pain signals from a specific part of the body from getting to the brain. Pain and other messages travel through the nervous system as electrical impulses. Regional anesthetics work by setting up an electrical barricade. They bind to the proteins in neurons' cell membranes that let charged particles in and out, and lock out positively charged particles. One compound that does this is cocaine, whose pain-killing effects were discovered by accident when an ophthalmology intern got some on his tongue. It's still occasionally used as an anesthetic, but many of the more common regional
That was by accident, I'm sure.
have a similar chemical structure and work the same way. But for major surgeries where you need to be unconscious, you'll want something that acts on the entire nervous system, including the brain. That's what inhalational anesthetics do. In Western medicine, diethyl ether was the first common one. It was best known as a recreational drug until doctors started to realize that people sometimes didn't notice injuries they received under the influence. In the 1840s, they started sedating patients with ether during dental extractions and surgeries. Nitrous oxide became popular in the decades that followed and is still used today, although ether derivatives like sevoflurane are more common.
That's whippets.
Inhalational anesthesia is usually supplemented with
How do you know that?
venous anesthesia, which was developed in the 1870s. Common intravenous
I recently
agents
found
include
out what
sedatives like
it's
propofol, which induce unconsciousness, and opioids like fentanyl, which reduce pain. These general anesthetics also seem to work by affecting electrical signals in the nervous system. Normally, the brain's electrical signals are a chaotic chorus as different parts of the brain communicate with each other. That connectivity keeps you awake and aware. But as someone becomes anesthetized, those signals become calmer and more organized, suggesting that different parts of the brain aren't talking to each other anymore. There's a lot we still don't know about exactly how this happens. Several common anesthetics bind to the GABA-A receptor in the brain's neurons. They hold the gateway open, letting negatively charged particles flow into the cell.
Chloride specifically.
Negative charge builds up and acts like a logjam, keeping the neuron from transmitting electrical signals. The nervous system has lots of these gated channels, controlling pathways for movement, memory, and consciousness. Most anesthetics probably act on more than one, and they don't act on just the nervous system. Many anesthetics also affect the heart, lungs, and other vital organs. Just like early anesthetics, which included familiar poisons like hemlock and aconite, modern drugs can have serious side effects. So an anesthesiologist has to mix just the right balance of drugs to create all the features of anesthesia, while carefully monitoring the patient's vital signs and adjusting the drug mixture as needed. Anesthesia is complicated, but figuring out how to use it allowed for the development of new and better surgical techniques. Surgeons could learn how to routinely and safely perform C-sections, reopen blocked arteries, replace damaged livers and kidneys, and many other life-saving operations. And each year, new anesthesia techniques are developed that will ensure more and more patients survive the trauma of surgery.
Great video. That's a really great video. So, super cool. By the way, cocaine. Lots of our local anesthetics are derivatives of cocaine. So lidocaine, benzocaine, right? A lot of those drugs are derived from cocaine. They have less addictive qualities to them. Right? Cocaine is complicated because it also involves like dopaminergic pathways and things like that as well. And speaking of addiction, a lot of these drugs, like I said, propofol killed Michael Jackson. A lot of these drugs can be very addictive. I was talking to an anesthesiologist when I was living in New York doing my clinicals out there, and he was like an older guy. He was probably like in his 70s, and he was retired, but he said he knew lots of anesthesiologists who died on overdose because anesthesiologists sometimes dip into their own supply. It's not uncommon for that to happen.
Ketamine, Matthew Perry. I think ketamine.
That's what killed him. I did not know that.
Are you talking about the dude from
Friends.
Friends? Yeah, he died on ketamine while he was in his bathtub or his jacuzzi or something. Ketamine is fatal in certain doses, right? So ketamine in lower doses has a dissociative type effect. It's also, been pretty widely successful in the treatment of refractory depression in certain patients. So you're seeing ketamine clinics nowadays popping up all over the place. And because it's very effective in treating depression, at least temporarily, it works for like 3 weeks at a time or something like that. So you have to like keep on going in to get a ketamine infusion. But it's better than not getting it treated at all because sometimes people with severe depression, they sometimes wind up killing themselves, right? That's the worst consequence of really bad major depressive disorder. So
basically, the anesthesia, it binds to GABA and allows chloride ions.
yeah, so that anything that binds to GABA receptors is going to be involving negatively charged chloride ions. And then if it's involving like local anesthesia, like lidocaine, for example, benzocaine, those ones block sodium channels. So here's a really cool discussion again on the reticular formation. We talked about the reticular activating system. You guys, that was part of your exam last week. Right, these are the guys who discovered the reticular activating system. It was discovered back in the 1950s. These guys, Giuseppe Maruzzi and Horace Magoon. And those are the guys who basically discovered that once you basically take out the reticular activating system, that's how you're able to put the patient into like a coma, for example, right? If the reticular activating system doesn't work, you're comatose. But if you're also doing anesthesia, it's going to be affecting the reticular activating system as well. And I've been reading this book, Dr. Mark Solms. This guy is like such an amazing dude. I saw him speak like 3 times when I was living in New York. He's a Freudian type psychologist, and he works as a neuropsychologist. So he works in neuropsych, and probably one of the most brilliant guys I ever met personally. And this book is awesome. He basically talks about like an overview of neuroscience, all the different areas of the body or brain that are associated with consciousness, for example. And so he's talking about how general anesthesia rests on little more than various ways of modifying the output of this tiny system. He basically suggests that the reticular activating system, which involves tiny little nuclei within the brainstem that are like the size of match heads, and those little nuclei, he thinks, are basically, he's positing that that's kind of like the seat of consciousness. That's where consciousness comes from. It's just this tiny little area in the brainstem.
What's the book?
It is called, oh my gosh. Hold on one second. Let me just pull it up real quick. The Brain and the Inner World. It's awesome. The Brain and the Inner World. The foreword is written by Oliver Sacks, who is like another huge dude in neurology and neuroscience. So he wrote the foreword to that book. Oliver Sacks, another guy that practiced neurology out in New York, and he wrote multiple different books. One on different types of hallucinations, other effects of drugs. Oliver Sacks also was a pretty wild dude. I think he basically did like every drug in the book, and he talks about it in his books. He's an interesting guy. He actually, there's a chapter in there. He stayed away from opioids because his parents were also physicians, and he wanted to dabble in like opioids, and he shot up morphine at like sometime in the morning, and then he woke up. Just like, you know, they were talking about when you wake up from anesthesia, you feel like nothing happened, right? You wake up from like a dream, basically. And he looked at his clock. He's like, oh my gosh, it's like 9 o'clock. He like shot up at like 8 o'clock in the morning or 9 o'clock in the morning. And he woke up like an hour later, but it wasn't an hour later. It was the next day. And so he was like, whoop, I'm never touching that again. So he never touched an opioid again after that because it just frightened him so much. And that's how these drugs work. They're sedatives and they'll knock you out. You know, they'll render you unconscious, right? And some people like that because some people use these types of drugs because they're trying to escape other things in their lives that are causing pain. So these drugs are really powerful painkillers in general. They don't just kill physical pain, but they also kill emotional pain. So that's why a lot of people self-medicate using these types of substances, because they also have effects on their, psychological state. So classes of neurotransmitters, again, we're going to talk about these more and more later on, but some of the major types are going to be involving excitation. Right, so there's excitatory neurotransmitters. Those are involved in EPSPs, which are graded depolarization of excitatory postsynaptic potentials. And that's involving sodium influx. Right? Remember, when you have sodium coming into the cell, that stimulates the cell. Right? Glutamate is going to be one of the most common types of neurotransmitters that's involved in stimulatory processes. We're going to talk about glutamate quite a bit, especially when we discuss, for example, the basal ganglia. Glutamate is going to be heavily involved in that whole process. Same thing with GABA too. GABA does the opposite though. So GABA is going to be the opposite. It's going to be an inhibitory type of neurotransmitter. And so what are these involved in? IPSPs, which are inhibitory postsynaptic potentials. And again, chloride ions that are negatively charged flood into the cell, basically rendering the cell neutralized. It's not going to be able to do anything. It doesn't depolarize. It doesn't propagate any sort of signals. And GABA is going to be, again, one of the most important neurotransmitters involved in that process.
So GABA will bind to the chloride?
It binds to the protein channel, and then chloride ions can flood through the protein channel, right? So ions are able to flow through. So you have like chloride channels, you have sodium channels, right? So here's the example of it. Here's an image. So you got GABA that binds to the receptor, then it opens up the channel, and then now chloride ions can flood into the cell to help to hyperpolarize the cell. So it makes it super negative. So it doesn't do anything in terms of stimulation. Some neurotransmitters are going to have a combination of these types of effects, like Acetylcholine can do either or, depending on what tissues are involved, what cells are involved. Same thing with dopamine, serotonin. That's what 5-HT means, serotonin, as well as norepinephrine. So it really just depends on what receptors you're binding to and what the overall goal of the tissue is. So here's an example of how those neurotransmitters can work in the balancing act, right? So you have the excitatory postsynaptic potentials, inhibitory postsynaptic potentials. Excitatory is going to bring it closer to threshold. Inhibitory is going to pull it further away from threshold and make it more negative. And so those different types of neurotransmitters are constantly competing, basically, to stimulate or inhibit the neurons. But then once you hit threshold, that's when you actually get an action potential taking place. So here again is glutamate. Glutamate's effect, once glutamate gets released at the axon terminal, and then it has its effect on the postsynaptic potential, sodium is going to come in, and that's going to cause more of a depolarization effect. Versus inhibitory, chloride channels are going to be involved. It's going to be inhibitory effect. So it's going to hyperpolarize the cell. Here's another example of what's going on here. If you had sodium coming into the cell or even calcium coming into the cell, that causes depolarization. And then chloride ions coming in hyperpolarizes it. And if you have potassium efflux, that's also going to hyperpolarize the cell as well. So just understand those major concepts, excitation versus inhibition, and what kind of ions are involved in that. And again, GABA is going to be a really important component to a lot of your anesthetics. Did you have a question?
I'm just trying to make sure I understand. So these like GABA and glutamate are like the neurotransmitters that act like ligands to open
Yes,
the channels?
yes, they're ligands. That's a great way to look at it. There are ligands that have to bind to the receptor on a protein, on a membrane protein, right? Once it binds to that ion channel membrane protein, then it opens it up. Yeah, sorry I didn't clarify that. So glutamate binds to a glutamate receptor, it opens up sodium channels. GABA binds to the GABA receptor, it opens up chloride channels, right? So it's going to allow for movement of different ions. So again, GABA is going to be the most important inhibitory, one of the major inhibitory neurotransmitters. Drugs like ketamine, for example, they're going to be working on a different pathway. They're going to be involving glutamate. And so glutamate, again, that's going to be one of the most important excitatory neurotransmitters. And those can be also affected by anesthetics. So ketamine, glutamate, right? A lot of other anesthetics like propofol that we talked about works on GABA type receptors. So different drugs work on different types of receptors. So here's a couple of examples here. So here are some of your local drugs, local anesthetics like lidocaine, for example, bupivacaine. So those cane drugs, again, like derivatives of cocaine, they're going to have sodium channel blocking effects. And so here's the control. Without any drug, right up here, the neurons are able to fire properly and are able to do their thing. Once you administer lidocaine, those neurons are not going to be able to fire properly. Right? It's going to be blocking the sodium channel. Here's your GABA type drugs, right? So you have phenobarbital, diazepam, zolpidem, so propofol, right? Diazepam, that's going to be a commonly used benzodiazepine type drug, right, to treat anxiety. So if you know anybody that takes any sort of drug for anxiety, like Xanax, for example, Valium, right, those drugs basically work on GABA receptors. When you stimulate GABA receptors, why does it treat anxiety? Because anxiety has to do with like overstimulation of the brain. And if you're giving somebody a drug that stimulates GABA receptors, that brings down the stimulation of the brain. Alcohol also works very similar to that. Yeah, same. Anyways, alcohol does something very similar. But alcohol also does a lot of other things. Alcohol is known to affect dopamine receptors, opioid receptors, and a bunch of other stuff in the brain. So alcohol is a dirty drug. It affects lots of different receptors, and that's why alcohol is so awesome. But anyway, so if you stimulate GABA, you're basically hyperpolarizing the cell. So here's the control up on the top here. If you give somebody, for example, zolpidem, it brings the cell down to a really, really negative charge. So it hyperpolarizes the cell. Ketamine, here's ketamine's effect. So you have drugs that also cause neurodepression, fentanyl, morphine, ketamine. So ketamine basically attenuates the effects of the neuron. So it basically brings everything back down again. Right, so it reduces the amount of stimulation. Here are some inhalant drugs. Remember we talked about, or not we, but the guy in the video talked about ether. Right? Ether was one of like the OG anesthetics back in the day. Ether is one of your like volatile type of drugs. Halothane also works like that too. So again, these types of drugs reduce the amount of firing of the action potential. Right? It doesn't allow the nerve to reach threshold. All right, so let's move away from drugs a little bit, and let's talk about your membrane potentials. So here are the things that affect the membrane potential as well as the electric signal. Right, you have the concentration gradients of ions. If you disrupt those concentration gradients for whatever reason, maybe you have an ion imbalance, maybe you don't have enough potassium in your body, maybe you don't have enough sodium in your body, in your serum, that's going to affect concentration gradients of ions. The concentration gradient of the ion that's going to affect the neuron as well as the permeability. So membranes, again, are going to be selectively permeable. They're going to be selectively permeable to certain ions. Bless you. And what causes selective permeability? It's going to have to do with ion channels. Right? You also have, again, active transporters. Active transport requires energy. It requires energy in the form of ATP. Again, one of the most important ones is the sodium-potassium ATPase. I think it's like 70 to 80% of all the energy created by a neuron is dedicated to the sodium-potassium ATPase. So extremely important, right? Because you have to maintain those concentration gradients for you to actually get an electrical signal being conducted. So here is active transport. So active transport, again, requires energy to take place. And then ion channels, that's passive, right? That's basically just passive transport. Ion channels are going to remain open, and they basically just allow ions to move depending on the actual concentration gradient. So you move from a higher concentration gradient down to a lower concentration gradient. So simple diffusion, right? Versus active transport, you're going against a concentration gradient. That's why it requires energy. So there's been studies done in early neuroscience to look at which ions move in which directions and how and why and the things that affect ion movement. But one of the ions that's really important in maintaining electrochemical equilibrium is going to be potassium. Now, potassium, of course, is going to move down the concentration gradient in terms of its concentration, but it's also going to be moving down an electrical gradient as well. So you have to consider both electrical gradient and concentration gradient, because these are charged ions, right? They have their valence. When you talk about valence, like calcium has a valence of +2, right? Chloride, it's a valence of -1. So depending on how much, for example, negatively charged things are within a cell, that's going to dictate or have an impact on which direction ions move. So if you have lots of negatively charged things in a cell, for example, proteins within the cell are negatively charged, DNA is going to be negatively charged, that's going to attract positively charged ions. That's why sodium, whenever you open up a sodium channel, sodium just rushes right into the cell, right? And so that's going to be involving an electrical chemical gradient. So if you were to look at a membrane that's only permeable to potassium, for example, and if you were to put in like potassium chloride into a solution. So here's your membrane, right? And it's only permeable to potassium. You're going to have potassium moving freely in and out of or through the membrane without any issues, right? So until it achieves like a balance between both sides of the membrane. Now, if you were to increase the concentration of sodium chloride on one side of the membrane, then you're going to have movement to the other side, right? Or sorry, potassium chloride. It's going to move across the membrane, right? So it can try to maintain balance. But if you were to put an electrical charge to one side of the membrane, then that's also going to affect the movement of potassium. Right? Potassium is going to move away from the positively charged side, and it's going to move towards the negatively charged side. So that's what we talk about. That's what we mean when we talk about electrochemical gradients. And so that's referred to as the electromotive force. Yes?
So first, they operate with like the chemical gradient and then
concentration gradient. Yeah.
Concentration gradient.
Yeah, the chemical concentration gradient. And it's basically trying to achieve similarity on both sides, right?
And
So
then and once that happens, then it'll be more electrical.
no. So this is just simple diffusion, right? It's like simple diffusion trying to maintain the balance on each side. But if you were to put a charge on one side, like if you were to run a battery and have one side be negative, one side be positive, potassium is going to move from that positive side towards the negative side, right?
Okay.
So that's going to be the electrical gradient. So ions move based off of an electrical chemical gradient. So both of those factors are really important.
So basically, you're maintaining equilibrium.
Yeah, exactly. That's the whole purpose of this, electrochemical equilibrium. Right, because think about the charge of the cell. Remember, insides of the cell are going to be negatively charged across the board. So positively charged ions are going to be attracted to that, right, because of the charge. But there's also going to be an issue if you have too many of that one ion within the cell. The concentration gradient is also going to come into play as well. So if you have a lot of sodium within the cell and you have sodium channels open, sodium is not going to want to move into the cell anymore because there's already a high concentration of sodium inside. So concentration gradient and electrical gradient are going to be extremely important. And then equilibrium, of course, is where you have balance of both of those variables. So we're going to talk about the Nernst equation now. The Nernst equation is what is used to be able to determine the electrical chemical gradient of one single ion. And so if we're looking at potassium, for example, potassium is going to have an electrical chemical gradient where it's not going to want to move beyond a certain concentration inside or outside of the cell. So for potassium, it's going to be about 58 millivolts. So we'll talk about this in a second. So here's the Nernst equation. Again, I am not going to make you guys do any calculations in this class, but the Nernst equation, just understand the concept behind it. It's going to measure the electrical chemical gradient for one single ion. So you have Ex, that's what you're solving for. That's going to be the equilibrium potential. And different ions are going to have different equilibrium potentials. For potassium, it's going to be 58. There's going to be a couple constants. You have the gas constant, that's going to be R. Temperature is going to be another one of the variables here. You also have the valence. Remember we talked about how like potassium has a valence of positive one, chloride has a valence of -1, calcium has a valence of +2, et cetera, et cetera. You also have the Faraday constant, and then this is going to be involving natural logarithm. So that's what Ln stands for.
So should we know
Different. I'm not going to test you guys on. I'm not going to test you on the values. Just understand the concept behind the Nernst equation and why it's important. I'm not going to test you on the variables either. Okay.
So just know what it does.
Yeah, just know what the Nernst equation is used for. So here's a little video that describes what the Nernst equation, why it's
The Nernst
used.
equation is really a story about two opposing forces, the electrical potential versus the chemical potential. Let's use the classic example of a ball on top of a hill to illustrate our point. Now, when the ball is at the top of the hill, it has stored energy, otherwise known as potential energy. Potential energy is equal to the height of the ball times the mass of the ball
times the gravitational constant. If we let the ball roll down the hill and quickly apply an opposing force to stop the ball, that opposing force or kinetic energy must equal the potential energy in order to stop the ball. The Nernst equation describes a very similar process for the movement of charged particles like sodium, potassium, or chloride ions across a cell membrane. Like the ball on the hill that wants to roll down, molecules want to move from high concentration to low concentration. In other words, they want to move down their concentration gradient. The size of the concentration gradient can be quantified using the chemical potential equation. Now, if we want to prevent the charged molecule from moving down its concentration gradient, we must apply an opposing force. In this case, that opposing force is referred to as the electrical potential. Now, if we apply a sufficient electrical potential so there is no net movement of the charged molecule in or out of the cell, we will have reached the equilibrium potential. And that's exactly what the Nernst equation describes. In other words, the electrical potential represents the potential in millivolts, where there is no net movement of charged molecules in or out of a cell for a given chemical potential or concentration gradient. So now that we have a general sense of what the Nernst equation represents, let's describe the Nernst equation in greater detail. Now, the Nernst equation is typically denoted as such, where E represents the electrical potential given in millivolts, and X represents the identity of the charged molecule. R represents the gas constant, which equals 8.31 joules per Kelvin per mole. T represents the temperature in Kelvin, which equals 298 Kelvin at 25 degrees Celsius. Z represents the valence of the charged particle. For example, sodium and potassium ions carry a valence of +1, chloride and bicarbonate ions a valence of -1, and calcium ions a valence of +2. F represents the Faraday's constant, which equals 96,500 coulombs per mole. And finally, Ln represents the natural logarithm of x in over x out, where x represents the intracellular concentration of the charged particle, while x out represents the extracellular concentration of the charged particle. Both are given in moles. Now, there's a much easier way to remember the Nernst equation. I'll show you by simplifying it. First, we'll cancel out like terms. The Kelvin units in the gas constant and temperature can cancel each other, as do the mole units in the gas constant and the Faraday's constant. Next, let's convert joules to coulombs times volts, or V. And with that, we can cancel out the coulomb units in the gas constant and Faraday's constant, leaving us with volts. Now, if we solve for RT over F, we get 0.02567 volts, or 25.7 millivolts at 25 degrees Celsius, or 298 Kelvin. Next, let's change the natural logarithm to log base 10 by multiplying everything by -2.303, which yields -59.2 millivolts over Z. Now, let's say the intracellular concentration of the charged particle equals 10 millimoles, and the extracellular concentration equals 100 millimoles. Now, the log base 10 of 10 millimole over 100 millimole equals -1. So minus 59.2 millivolts over a Z of +1 times -1 gives us an equilibrium potential of positive 59.2 millivolts.
All right. Again, I'm not going to make you do any calculations on the exam.
The Nernst equation.
No.
First of all, what is the Nernst equation?
No more. We can stop. So yeah, like I said, I'm not going to make you guys do any calculations. Just understand the basic concept behind it. So here is what you would see if you, for example, changed the concentration of potassium. So if you change the concentration of potassium in a bath, that's going to affect the overall electrical gradient potential. So the higher the concentration goes up, and if you did it in a like by tenfold, for example, that would affect the electrical chemical gradient of the given ion. So for this case, it would be potassium. All right, this kind of already summarizes what you talked about a second ago. So this is showing how if you change the battery voltage, so you're going to change the voltage of the solution on either side of a membrane, that's going to affect the overall ability for potassium to move, right? So again, if you make the voltage more and more negative, it's going to attract potassium to that one side of the membrane. more so than if it became more and more positive, right? So the more negative you would have one side, it would basically allow for, or you would attract potassium to move in that direction, just because potassium is positively charged. If you increased the negative charge, then it's going to repel the potassium ions from that one side of the membrane. So over here, you have the battery. If it's turned off, potassium ions are basically just going to move down their concentration gradients. And so if you had more concentration on one side, it's going to move down the concentration gradient to the other side of the membrane. Once you start introducing a charge to the solutions, right, on either side of the membrane, that's going to have implications on the direction in which potassium is able to actually move. Again, making one side of the membrane more positive is going to repel potassium ions. Making one side of the membrane more negative is going to attract positively charged ions to that one side. Cool. Now, in terms of membrane potential, resting membrane potential, there's going to be a few major ions involved in establishing the membrane potential. So we already talked about potassium, but sodium is also going to be involved in this. Calcium is also going to be involved. Chloride ions are also going to be involved, right? And these can all be manipulated by different types of neurotransmitters, right? Like glutamate is going to affect sodium, GABA is going to affect chloride. We're going to learn about certain drugs that can also affect, for example, just potassium. We're going to learn about that later on. And so those are all going to be involved in your membrane potential. Now, for a squid neuron, the resting membrane potential is pretty similar to a human's resting membrane potential. It's going to be about negative 65 millivolts. For a human cell, depending on what cell it is, it's about like negative 71, about negative 70-ish. And it's really close to the electrical chemical gradient of potassium specifically. So potassium is going to be one of the most important ions involved in maintaining a resting membrane potential. The membranes are going to be way more permeable to potassium than any of the other ions. So more so than sodium, more so than calcium, etc. So potassium is going to be one of the most important in maintaining the equilibrium potential.
What's that E?
E is the equilibrium potential for an ion. And so here is comparison of squid versus mammalian neurons. So know where your ions live. That's going to be, pretty important in general. But potassium generally lives within a cell versus sodium, chloride, and calcium are going to live predominantly outside of the cell in higher concentrations. So the most important intracellular ion is going to be potassium. The most important extracellular ions are all the other ones: sodium, sodium chloride, and calcium. The squid neuron, about negative 75. The resting membrane potential is going to be heavily determined by potassium movement. So again, potassium can just move easily across the membrane. The human neuron or mammalian neurons are going to be a little bit different. So potassium gradients are going to be a little bit, there's going to be lower concentration of potassium within mammalian neurons. The other ions are also in lower concentrations, but relatively speaking, it's going to be the same type of ratios, right? It's going to be more potassium inside the cell versus the other ions are going to live more so outside of the cell. Chloride? No, chloride's going to be outside the cell. Yeah. You're going to have small amounts of the ions that the extracellular ions, you're still going to see small amounts inside the cell too, right? But in terms of the ratio, you're going to see a greater ratio outside of the cell for all the remaining ions. Now, there are different things that affect speed of a neuron signal. So if you have a bigger diameter to the neuron, that's going to make the speed a lot faster. Also, again, presence of myelin is going to be another really important factor, right? The more myelination you have, the faster the neuronal signal will be. Signals that are going to be a little bit slower, for example, like dilation and constriction of your pupils, those are considered like slower type signals. Really fast signals, you're thinking skeletal muscle. As soon as you think about moving a muscle, that happens instantaneous almost, right? So those are going to be much faster type of signals. Now the squid, the reason why squid has been used as an ideal model organism for neurology and neuroscience is because of the diameter of the axon. The squid axons are absolutely huge compared to the axons in a mammal. So this is a really cool video that shows stimulation, or at least like the use of a squid neuron in a petri dish. So not a super long video, just a couple minutes, so let's watch it.
The day starts actually with fishermen going to sea and collecting squid and bringing them back to us. At that point, we have the animals at hand and we can begin our preparation. From the squid, we wanted to then collect the giant axon. So this is the inside of the squid, and now we're going to do the dissection of the squid giant axon. And this is the cartilaginous backbone of the squid, which is called the pin. And you can see it looks like an old-fashioned writing pen. And I can also use this to point to different parts. So all of these lines that you see here are axons. They're all coming from this body of neurons right here. So all of these are innervating the muscle. And the biggest of these axons is the squid giant axon, and it lies right along the pin, right in the middle here. So this is the axon that we're going to have to dissect out. And there's one on either side here. So the next step is to dissect out that axon. We had to very carefully get the giant axon, tie it off, remove it from the squid. And here we are removing the giant axon, and also kind of a protective sheath that is covering it. There. Now we've got inside of here our giant axon. And we'll have to clean it up later, but that is the starting prep for removing it from the squid. So this is the squid giant axon right here. What I'm doing is cleaning all of that sheath and kind of material that is covering the squid giant axon. Then we needed to get the inside of the squid axon out. That can be done fairly easily just by cutting it. And then you can squeeze out the inside of the giant axon, more or less like rolling out toothpaste from a tube. And that rolled out axoplasm, which is the inside of the squid axon, was the starting point for our preparation.
Cool stuff, huh?
Did we watch the video with him before this class?
He looked really familiar.
I was thinking the exact same thing.
Yeah, he looked really familiar.
Okay.
Oh, he's the guy who discovered kinesin and dynin.
Okay.
Yeah, now I remember. That's.
Okay.
I'm like, that looks really familiar. Yeah, interesting guy. Anyways, so again, the squid axon is huge. So way bigger than a mammalian axon, up to 1,000 times larger. And so that's why it's, heavily used in neuroscience research. Another reason why is you have a really big diameter to the axon, which also helps to propagate a signal much more rapidly. And so here's the squid anatomy. So you have all those tentacles here, then you have the brain, and then you have first order neurons within the brain, then you have second order neurons, and then you have these little ganglia over here. And these satellite ganglia, those are the ones that are attached to those third order neurons, and those are the ones that basically innervate the muscle of the squid mental. So the mental is going to be this whole entire section over here. The whole entire section over here, that's considered the mantle of the squid. Now, look at the size of the diameter. So this is from your textbook. So the textbook did a comparison. If you were to compare like a human diameter of a neuron, compare that to the squid diameter of the neuron, it's way, way larger. So much bigger in terms of diameter. And so that also helps to propagate signals really, really rapidly. So you can see some significant effects on changes of ion balances within the neuron. Again, potassium is going to be really important in maintaining the resting membrane potential. O versus I. O is out, I is in. You're going to see a balance between potassium that's inside the cell versus potassium that's outside the cell. And then once you reach equilibrium, potassium inside of the cell is going to be way higher than the potassium outside of the cell. And then remember that the neurons are going to be way more permeable to potassium ions than any of the other types of ions that you see. And then 58 millivolts, that's going to be where you find the resting membrane potential for potassium ions. And as you increase the external concentrations of potassium, that's going to affect the resting membrane potential as well. And so as you increase potassium, here's your resting membrane potential at the bottom. So increase extracellular concentrations of potassium, the resting membrane potential is going to go up and up and up. And so that's going to affect the actual resting membrane potential. So potassium is really important in this whole entire process. Now, if you want to complicate things and look at a more real-world scenario where you're balancing all the various ions, this is when you use the Goldman equation. The Goldman equation is going to be involved with multiple different ions, potassium, sodium, chloride, etc. Let's watch a little video on the Goldman equation.
But in real life, things are a bit more complex. First, in the body, multiple ions coexist together. So to find out the combined equilibrium potential, we need to take them all into account. The important among these are potassium, sodium, and chloride ions. And second, the permeability of the membrane varies for different ions. If a membrane is not permeable to a particular ion, that ion will not diffuse, and therefore it will not contribute to the development of potential. So when calculating the combined potential, we need to take into account the permeability also. The formula to calculate the exact potential was given by David E. Goldman. And it goes like this. It's like the Nernst equation only, but more complex. Here, C means concentration and P means permeability. This portion represents the contribution of sodium. This portion represents potassium, and this one is for chloride. Under resting conditions, the membrane is permeable to potassium, but its permeability to sodium is very less. So under resting conditions, the potential is largely determined by the diffusion potential of potassium. That is why the resting membrane potential in most cells is about minus 70 millivolts, which is close to minus 94 millivolts equilibrium potential of potassium. However, when the cell is stimulated, the sodium channels also open, and they also contribute to the potential, as the equilibrium potential for sodium is plus 61 millivolts. Overall, there is a shift toward a positive direction. And that's the reason why we see depolarization in action potential. So now you know the math behind depolarization also. So this was the Goldman equation. Now let's have a quick summary. If charged ions diffuse across the cell membrane, the resultant electrical potential opposes further diffusion of those ions. The exact potential where diffusion stops depends on the concentration gradient and charge on the ion, and it can be calculated by the Nernst equation. In real life, multiple ions contribute to the final equilibrium potential, depending on their permeability. In such a case, the potential can be calculated using the Goldman equation. That's it for this video. Click here to read the notes on this video at our website. You can also explore our entire physiology animation video library.
That dude's so funny. He sounds so angry when he talks about it. But, so anyways, Goldman equation in general, going to be more of a real life type scenario. So you're not just looking at one single ion. let's see here. This kind of already talks about what we just discussed, right? It talks about the different concentrations and the permeabilities. Now, this kind of plays off of the Goldman equation, right? Where you look at the permeability of different ions. Again, your cells are going to be permeable to potassium, basically. Like potassium is going to freely flow in and out of the cell. Sodium, however, is only going to flow into the cell once you open up those voltage-gated sodium channels. And so once you reach threshold, you open up those voltage-gated sodium channels, then you have permeability of sodium. Whereas potassium is basically going to be permeable throughout the entire maintenance of the resting membrane potential. Again, to reiterate, permeability of potassium is going to be what helps to establish the resting membrane potential. The resting membrane potential is going to be negative, right? So you have resting membrane potential is negative and approaches the equilibrium potential for potassium. So that's what basically determines resting membrane potential. And it's only going to change once you actually make the cell permeable to sodium. At rest, sodium is going to be coming into the cell a little bit, but it's not so much. It's going to be less permeable. It's still a little bit permeable, but less so. Now, what establishes the concentration gradients of sodium and potassium? Again, sodium-potassium ATPase. That is the most important enzyme and one of the most ubiquitous of the channel proteins that you'll find in your body. Not just neurons, but other places as well, other cells throughout your body. Now, if you were to affect sodium concentrations, that's also going to affect the ability for the neuron to depolarize. So we talked a little bit about this a second ago, earlier today, when we were discussing like if you had hypernatremia versus hyponatremia, right? If you had hyponatremia, you had low sodium, that's what happens. You don't get a really good action potential. It's not going to depolarize nicely. That's why you get hyporeflexia. That's why you might get flaccid paralysis if you have hyponatremia. Similarly, if you're using a sodium channel blocker like lidocaine or benzocaine or one of those types of drugs, that's going to reduce the ability for sodium to come into the cell. It's going to reduce the ability for you to get proper action potential. And if you affect sodium, then your resting membrane potential is going to remain stagnant, right? It's not going to be affected. You're not going to get any sort of depolarization whatsoever, right? And so that's going to be the effect of, for example, certain drugs or conditions like hyponatremia. And then these are the different phases that you see in an action potential. We have the overshoot phase, we have the falling phase, and then an undershoot phase. The overshoot phase is basically the tip of like the depolarization. When you see like a depolarization graph, the overshoot is going to be the very tip. Then you have the falling phase going back down to repolarization, and then the undershoot is going to be where you have hyper repolarization until it goes back to its normal resting membrane potential. And then you're going to see differences in these types of action potentials depending on what neuron you're looking at, right? Resting membrane potentials, threshold, the peak of the overshoot, all that is going to depend on what kind of cells you're looking at. So it depends on if you're looking at Purkinje neurons within the cerebellum. It depends on whether or not you're looking at motor neurons, as an example. So different cells are going to have different resting membrane potentials and different thresholds and whatnot. So this is a graph that comes from your textbook. I'm not going to go into detail about it with this, but it goes into different types of cells and what they all look like. And let's do a quizzes question before we wrap up.
That was the fastest we've gone through a slide deck.
I know, right? I was hoping to get into part 2 as well, but unfortunately, we have 10 minutes left. You guys want to get started into part 2? You guys want to do like maybe a couple questions and quizzes?
I feel like it benefit us if we fit it all in.
You want to start doing that? You want to get into part 2? Oh no, so you want to do part 2 next time? Okay, fine. Okay. Deal. Huh?
Instead of everyone else wants to get sorted, I don't.
Slackers. I know it's a lot of information, but
So our exam 2 is after spring break for this week.
is it?
Yeah, right after.
Oh, I thought it was right before. Are you sure? Should we make it before?
Just about to say,
I think we should make it short. I don't have to worry about it.
yeah, and from that, we'll know.
Well, that also gives me more time to write the exam if we do it after spring break. No, let's do it after spring break because we're going to be covering a lot of material before then, so we'll have to cover it. Yeah, sorry. Hey, you can study during spring break, right? Right? You have an Indian wedding? Those are the best. Like 3 days. How many days is it? 3?
3 main days.
That's awesome.
I have 4 different outfits.
I've only been to one Indian wedding. It was epic. I think my buddy spent my buddy and his family. I think they spent like close to $500,000. It was insane. He rode in on a giant horse. Yeah, that's awesome. Is it going to be here in Arizona? Oh dang!
That's it.
Oh cool.
Oh, she's going to Cancun for spring break.
Maybe you'll see.
Hey, there you go. You might bump into each other. All right, let's do some quizzes questions. So again, resting memory potential varies from cell to cell, right? On average, about 70-ish, right? But it can be between -40 to -90.
What's the reason that some are 40 and some are
I don't know. I think it has to do with just like the function of the actual cell. Yeah. So, but yeah, I don't know. It's a good question. A good question where I don't have a good answer. I guess it says differences in membrane permeabilities. That's what kind of determines. I guess different cells have different permeability.
Okay.
Yeah, so some cells might be more permeable to potassium, some not as much.
So like you were saying,
I guess.
like, based on what their function.
Yeah, I guess it depends on what their function is. How will a neuron respond to an injection of a negative current? Okay, so hyperpolarization. So think about ion movement. Remember how GABA works? Right, GABA is going to be working by allowing chloride ions to enter into the cell. So this is kind of be similar idea, right? If you were to actually inject the cell with like a, what's it called? A probe, right? If you were to actually like reduce the charge of the cell, it's going to cause hyperpolarization. Depolarization is the opposite, right? So if you hit threshold, that's going to cause depolarization, which would also have a positive electrical response. So that would be the same thing. So hyperpolarization. So remember, amplitudes do not change. So some amplitudes might be different depending on the neuron, but within that given type of neuron, it's always going to be the same. The only thing that changes is the frequency, right? The higher, the greater number of frequency, the greater the actual effect of the neuron, right? It's not going to involve amplitude. So remember, with a reflex, like for example, patella reflex, it's going to involve three different things, right? You have your afferents coming in, so you have your receptors, right? That's going to be your afferent. So you have your receptor potential, then you have your synaptic potential that's between the afferent fibers and whatever nerves that it's going to be affecting, and then you have the ultimate action potential that causes the reflex to take place. So, for example, you have your afferents coming in to your spinal cord. They're going to innervate either the extensor muscles or the flexor muscles. Then you have the interneurons coming in that are going to prevent the flexor muscles from firing. And then you have the extensor muscles are the ones that actually fire. And the extensor muscles are going to be involved in the action potential, right, down the axon. So pretty straightforward stuff. You got to depolarize the cell until it reaches the threshold. And then once it reaches threshold, that's when you get the full-blown action potential taking place. So most of you guys got that correct, so that's great. You picked the wrong one. Just don't do that on the exam day.
You're reading these questions really fast. So.
So if it's sub-threshold, meaning that you're not going to get a full-blown action potential, it's going to eventually decay. So that's considered a passive type signal. Remember, the passive signal just kind of flows through and it just kind of dissipates over time, especially over distance. So that's where you have sub-threshold. You didn't hit threshold. If you hit threshold, then that would involve active electrical signal, and then you would have a constant signal along the entire duration of the axon, assuming that it doesn't have any damage, like to the myelin, for example. So let's do one more question, and then we'll dismiss. And you guys can do the rest of the questions between now and Thursday. So hyperpolarization, that's the whole idea behind anesthetics, right? You keep the neuron hyperpolarized, whether it's through a sodium channel blocker or if you're administering a drug that allows for chloride ions to come in, like a GABA type drug. So hyperpolarization. Rock and roll, guys. Finish the rest of those on your own, and then we'll continue part 2 on Thursday. And then hopefully get into part 3 as well, because there's still quite a bit of material to cover. Any questions? Cool. All right. Have a great day, guys.